Hello again. This is the October EMS summary review. There's two cases that we talked about this month. The first was a 65-year-old female with bad head trauma. We had talked about how getting a good neuro exam is important, especially for the providers that you're handing off to, whether that's your formal exam and having the patient follow commands, but also the informal exam and just noting that, yes, they moved all extremities purposefully when you're getting them from the scene to the hospital. You saw, yes, they moved their right leg, even if the patient can't follow commands and move their right leg. Are they talking? Again, your formal exam is important, but so is the informal exam, particularly as it relates to subdural hematomas. And again, just anecdotally from working at the trauma center, neurosurgery often wants to know a really detailed exam, and often it can make a decision about whether they take that patient to the operating room to take their skull off, so to evacuate the blood and let the skull sweat or let the brain swell. Epidurals more often happen because of an arterial bleed, and they more often go to the operating room, but subdurals, they can accumulate slower, and again, the exam matters and the timeline matters. So an intoxicated guy who falls on the stairs and is found 12 hours later with a really poor neuro exam, even though he's got a subdural hematoma, probably not going to the operating room because the prognosis is going to be really poor. So make sure you get a good exam, which the medics did in this case. I thought everything went fine in this case. Discussion also, we talked about a few other things related to this, to head trauma. One of them was a discussion about blown pupil, and I shared a Google document that you'll see related to that. The takeaway point is that if you have a patient with a blown pupil and head trauma and they're talking to you and awake, the head trauma is not causing the blown pupil. There's some other reason why they had a blown pupil. You can't have a blown pupil in a normal neuro exam because to get a blown pupil, your brain is squeezing out the bottom of your skull. And if that's happening, you won't have a normal neuro exam. So we talked a little bit about perseverating and closed head injury. Again, closed head injury being the more common term, or the sort of newer term for concussion, and that concussion, your closed head injury is on a spectrum from way over here where you get your bell rung, you maybe didn't even lose consciousness, but you certainly feel off. So that's kind of the low end, and then over here you get to subdurals, epidurals, like super bad head injury, obviously, that we were just talking about, that needs to go to the operating room, usually from big trauma, right? And perseverating doesn't necessarily predict where you'll be on that spectrum. It's just something that happens with closed head injury. The patient keeps asking, and perseverating is the patient asking the same question over and over again. So what happened? You tell the patient, and 2 minutes later they say, what happened? It just happens over and over again. So that's perseverating. Concussion, another point about blown pupils, and I mentioned this just because you see it so often in the media, and it's really stupid. It doesn't help anybody. The patient will be evaluated, and somebody look at their pupils and say, yes, you have a concussion. And the next show you watch, they'll look at the pupils and say, no, you don't have a concussion. A pupil doesn't tell you anything about concussion. So it's meaningless. So anything time you see that, don't. And again, the reason I mentioned it because of the media, not for us so much that we get our education from the media, but that's the population that you see. So parents, coaches, people on the sideline, when somebody gets their bell rung, somebody wants to do a pupillary exam, and sure, do it, but that's fine. But it's not going to tell you whether they have a concussion or not. If you look at the pupils, it doesn't tell you anything. And again, if the pupil is blown, you're not having a discussion about that. You're doing other things because the patient is really sick from that head trauma. So anyways, just keep that in mind. It's kind of meaningless. The last thing that we talked about related to, we went from head bleeds to strokes, discuss briefly, because again, there's some types of head bleeds from trauma that's usually in the frontal lobes, which are similar to hemorrhagic strokes. Again, the less common type of stroke, although that's usually in the middle part of the brain where you have a hemorrhagic stroke. And again, trauma usually causes issues in the front of the brain, and those types of bleeds called intraparenchymal hemorrhages or contusions. So, but it led to a discussion about strokes and dizziness. Typically speaking, like vertigo symptoms, like really bad spinning, like either the patient says, I'm spinning, or the room is spinning, more often, or most of the time, those are from a peripheral cause. So the more severe the symptoms, the more likely it's a peripheral cause, something to do with the middle ear and the semicircular canals and the crystals in there. This is not universal, but again, most of the time, the more severe the symptoms, the more likely it's a middle ear thing and not a dangerous type thing. The more subtle symptoms, like a patient that can't walk or they're listing, that more often is concerning for a posterior circulation stroke. So but posterior circulation strokes are a much less common type of stroke as well. They're usually ischemic, they're not usually hemorrhagic, but they're much less common than the typical stroke in the rest of the brain that causes your textbook stroke symptoms. So we're not going to change any practice. If you have a patient with dizziness, you don't need to run them code 3 to the ER for a stroke code. But if you get there and the provider examines the patient, they may upgrade them to a stroke code if there's suspicion for a posterior circulation stroke is what's going on. So what we're doing in practice, I think, is fine. We'd be running a lot of people code 3 to the ER unnecessarily if we took every patient who had dizziness. And again, they're just not, those types of strokes are not very common. So the second case that we talked about was a 48-year-old guy with WPW. again, this was managed fine. The medics were not forced to act. And then as the case unfolded, they got to the ER, and then even the doc and the ER doc wasn't sure what to give. They called called the pharmacist, called cardiology. Eventually, he tried something, he tried adenosine, and it worked. But the discussion got into, can we give adenosine or not with WPW? And again, I think we've all learned this at some point, and in the back of our heads, like, yeah, you can, but maybe not, right? And so, again, I had to look this up a couple of times, and I feel like I have an understanding of it, but by the time I actually see another patient with WPW, I probably am going to forget the details of it. So a takeaway point is that if you have a patient with WPW, or essentially any cardiac rhythm that's too fast, electricity is always a safe answer. If you really need to act and the patient's crashing, electricity is a safe answer. If you can't remember the adenosine or not, it's like, yes, we can in this type, because in WPW, if you have narrow complex and it's orthodromic, then you can give adenosine because it is a type of SVT. If it's antidromic, then it's going on a different pathway, and you don't want to slow any conduction through the AV node, which is what calcium channel blockers, beta blockers, digoxin, and adenosine all do. So you can, again, if you're confident of your diagnosis, you can give adenosine. But again, I think most of us are going to be like, yeah, I know there's something I don't quite remember, but I could cause more harm. I would probably write it out and get to the ER. Again, I wish I had that detail securely in my head and I could diagnose every EKG that was WPW and for sure just come right to the right conclusion. But I think realistically, when we see it so rarely and we talk about it so rarely, I don't know that that's going to happen in practice. So again, electricity is safe if you need to. If not, keep it. And if you don't need to act, I think it's perfectly fine to get to the ER and talk about it there. So that's all I got this month. We'll see you next time.